Okay, so I want to talk about some common concerns with reproductive health for women. This is not an exhaustive list. You're going to get it more of this next year. We're not addressing anything to do with pregnancy because we're going to cover that in later units in this semester. So this is just some common reproductive concerns that women may deal with. This recording is going to be about menstrual disorders. So this is another time to get out your vocab notebook. What do you think amenorrhea might mean? If you break it down, A means none. So this means we don't have something. Meno is menstrual. Rhea is going to be bleeding or discharge. So this is someone who's not having a period. Amenorrhea, not having menstruation, is either primary or secondary. Okay, primary means that this person has never had menstruation. They have had no menarche, no secondary sex characteristics by 13, or no menarche by 15. Secondary means they've had periods before and now they've stopped. The most common cause of secondary amenorrhea, write this down. The most common cause of secondary amenorrhea is pregnancy. It does not matter what health problems your patient has had. If they still have a uterus, if they have had periods in the past and they do not now have a period, do a pregnancy test. Okay. So the most common cause of secondary amenorrhea is pregnancy. There is also a relationship with body fat. When women are losing weight, as their body fat percentage falls, they may have temporary amenorrhea. And women who are very thin, who have very low body fat, may actually stop having periods altogether. Okay. Be aware that at any time they could ovulate again, and so they may become pregnant unexpectedly. But there's a relationship between menstruation and body fat. And when body fat percentage is too low, someone may have amenorrhea. So some potential causes, there can be anatomic abnormalities. This is more likely if someone has secondary sex characteristics and has primary amenorrhea, they've not had a period. It may be that they're menstruating, but the blood can't get out. Okay, so maybe some anatomic abnormalities. There also may be hormone abnormalities. The hormone system has some multiple steps. So we could have an issue at the endocrine level with the hypothalamus or the pituitary. We could have a problem at the gonad level. The ovaries may not produce hormones appropriately, or we could have problems at the uterine level. So we may have endocrine disorders. There may be pituitary lesions that's part of that endocrine system. The hormones may be being suppressed for some reason. Stress can cause alterations in hormone levels. Stress is notorious for delaying ovulation and causing someone to have late periods. So it's not uncommon. Sudden severe weight loss, an eating disorder, strenuous exercise, or mental illness can all alter hormone levels. There's something called female athlete triad. It occurs with athletes who've been encouraged to train so hard that they lose their menstrual cycle. They stop having a menstrual cycle. Female athlete triad is amenorrhea, I believe bone loss, and disordered eating. And there are some sports that are more likely to contribute to female athlete triad. Dance, gymnastics, running, all of those favor body types that have less female secondary sex characteristics. And so girls growing up in those sports may be encouraged to diet or train to the point that they stop menstruating, which can lead to osteoporosis and long-term disordered eating. So be aware of female athlete triad as a possibility if you have a very thin athletic person who's not menstruating. The management for amenorrhea is based on the cause. Okay, if it's obstructive, they try to do something to relieve the obstruction. If it's hormonal, they're going to try to adjust the hormones. So the management of amenorrhea is depends on the cause. Now, amenorrhea for a lot of women is not problematic to their lives. It's actually more convenient not to have menstrual cycles. So the major reason to address amenorrhea is to find out if there's a problem that needs to be treated. Dysmenorrhea is pain during or before menstruation. It's more common in young women. Primary dysmenorrhea begins 6 to 12 months. In the first 6 to 12 months of menstruation. Secondary amenorrhea develops after several years of menstruation. Primary amenorrhea is mostly benign. It may be due to excess prostaglandins. It can be managed with usually non-pharmacologic measures, but there also are some meds that might be used. So heat, massage, relaxation exercises. There are some other things like meditation, exercise, decreased salt and refined sugar, eating diuretic foods, decreasing fat and red meat. All of those may actually improve menstrual cramps. NSAIDs are the most common first line of defense for menstrual cramps, and most women have taken some NSAIDs at some point in their lives for cramps. If cramps are impeding someone's life, and if they desire contraception, oral contraceptives are helpful in suppressing some of the hormones. So oral contraceptives tend to make menstrual cramps better. Secondary amenorrhea is more likely to be pathologic. So if someone has been having periods for a while and they've been fine, not been painful, and they develop painful periods later, or it gets worse as they get older, it needs to be evaluated. Some causes can be fibroids. Fibroids are benign muscle tumors in the uterus. They can make it difficult for the uterus to contract, and so they can cause more painful contractions. Endometriosis, when endometrial tissue is implanted in other locations in the body, and then with the hormone influence of menstruation, that can cause pain. That can cause pain in other locations. Endometriosis also tends to cause inflammation and scarring, and it can lead to infertility. Infections and inflammation can cause worse menstrual cramps, clearly, obviously, because inflamed tissue is going to hurt more when it's contracting. The management of secondary amenorrhea is focused on trying to either fix or alleviate the cause. Some of those things are not really curable, but there's things that we can treat to decrease the risk. Okay, so next is premenstrual syndrome. This is a pattern of mood and or physical symptoms that happens before menstruation during that luteal period. An example of that would be luteal phase headaches. There are some women who get headaches in the 2 weeks before their period every single month. If it's primarily mood symptoms and they're severe, then it's called premenstrual dysphoric disorder, PMDD. But if it's both mood and physical symptoms, it would be PMS, premenstrual syndrome. The symptoms begin around ovulation and they build through the luteal phase, and then they're relieved at the onset of menstruation. So this is not cramps. Cramps occur usually just before and during a menstruation. This is symptoms that lead up to menstruation. They begin around ovulation. Management, you want to have that patient keep a log of their symptoms daily to try to find a pattern. Some things that can be helpful are decreasing caffeine, sugar, alcohol, and salt, a general healthy diet, encouraging some diuretic foods, calcium, B12. Evening primrose oil is an herbal that's been recommended. Exercise, yoga, acupuncture, hypnosis, massage. There are a lot of alternative treatments that people have found helpful. Okay, so medications that may be used, diuretics, may be helpful because some of the symptoms may be due to fluid retention. NSAIDs if there's pain, progesterone, oral contraceptives may be helpful for physical symptoms. Sometimes oral contraceptives can actually help with all of the symptoms because they suppress ovulation. SSRIs may be used for emotional symptoms. That's things like Prozac or Zoloft. Okay. Endometriosis. Endometriosis is the presence and growth of endometrial tissue outside the uterus. I'm going to pause for just a second. One of the things that you're going to see that's different in this semester, because last semester was fundamentals, we were covering the basics. This semester, we're getting into more specifics. You're going to have a lot of diseases and disorders covered. And you might want to develop a method of taking notes about and understanding those. So you want to look at what's the pathophysiology of that thing, what is happening with that problem, okay? And then what does that look like for the patient? What are the signs and symptoms? And then what are the possible complications of that? And then what's done about it? What's done medically about it? And what nursing care can we do? So that's kind of the way these are set up, and you'll see that pattern. I would go back and re-listen to any pieces of lecture that have specific diseases and disorders in them and find a way to make notes about those so that you understand them and that makes sense to you. Definitely begin with what is the name of that condition and what does that mean? Okay, so you're not getting conditions mixed up. You don't want to mix up amenorrhea and endometriosis, for example. Okay, so endometriosis is a disease in which endometrial tissue grows outside the uterus. Okay, we don't know what causes it. There are some theories about how that endometrial tissue gets out of the uterus, but we don't really know what causes it. We do know what happens when that tissue gets inflamed and tries to shed every month. It causes pain, inflammation, and adhesions, which means over the years, over time, those things get worse. So over time, those periods get worse. Women with endometriosis begin to have abdominal pain even when they're not menstruating. Intercourse may be painful because of adhesions. They may have chronic diarrhea. They may have pain with defecation, and they may have constipation. They may feel heaviness in the pelvic area. Over time, those adhesions can cause complications with the bladder, with the intestines. They can also, over time, impair fertility. So the goal is to diagnose this early so that it can be managed to preserve fertility for that patient that wants to be able to bear children, but also to be able to give that person the best quality of life possible. If the pain is mild, NSAIDs are used more often once endometriosis is discovered. That person will be put on continuous oral contraceptives. The idea is to suppress endometrial growth completely. That treats the symptoms now. It stops the pain and inflammation and the swelling. It prevents those adhesions that cause complications later. It also preserves fertility so that person can decide later if they want to have children. Remember that the longer someone goes with untreated endo, the more likely they are to have complications. There are also meds that suppress GnRH. Remember that hormone way back that the hypothalamus produces? There are meds that suppress GnRH. And then there are meds, sometimes they're given androgenic steroids. Both of those classes of meds decrease estrogen, produces a medical menopause, which prevents endometrial growth, and it may cause some of that endometrial tissue to regress. But both are reversible. So if endo is severe, they may use those meds to induce menopause temporarily. Usually they would recommend that that be timed so that the patient is ready to conceive fairly soon after stopping those and return of fertility. Oral contraceptives, the continuous oral contraceptives, typically women with endometriosis who are taking them for that reason, if they plan to conceive, they're advised to do that pretty soon after they stop the oral contraceptives. Okay. If it's severe, then a total abdominal hysterectomy with bilateral salpingo-oophorectomy, TAH with BSO, is curative. Okay, they just remove the uterus and the ovaries. Endometriosis is considered cured. It tends to stop the pain, stop the inflammation, stop the development of fibroids. If a person is having severe endo complications and they have failed the other therapies, or the other therapies have failed them, and they want to try to maintain fertility, then a laparoscopy may be used to remove some lesions, or laser therapy may be used to remove some of those lesions to try to improve symptoms. So endometriosis is common. It also is a common delayed diagnosis. Remember when I said that women who have who present with symptoms are frequently, their symptoms are frequently downplayed by providers. It's very, very common for people with endometriosis to be kind of written off as just complaining a lot about menstrual pain or wanting attention. And so that gets ignored. So sometimes women have to be more assertive about trying to get some assessment for what's going on. Okay, alterations in bleeding. These are just some general alterations in bleeding and potential causes. These are not diseases, they are symptoms. So oligomenorrhea means they're not going frequently. They're not having menstruation frequently. Okay, it's someone may say they have irregular periods, or they may say I only have a period every few months. Oligomenorrhea is infrequent. If the underlying cause, we need to find out what the cause of all these is. If the underlying cause is not causing other health risk and that patient is not trying to conceive, then oligomenorrhea may not be treated. Okay. Oligomenorrhea can also be a side effect of some types of birth control. Hypomenorrhea, their periods are scanty. They're very light periods. Well, that doesn't sound like a problem either. So again, we want to find out if the underlying cause is something that has other risks, and if they're trying to conceive. Because if they're trying to conceive and their periods are scant, that may indicate some hormone issues. So if they're not trying to conceive, and if the underlying cause is not causing, doesn't have other risk, then hypomenorrhea may not be treated either. Menorrhagia is heavy periods. Okay, this is life impacting. There are women who actually cannot leave the house for 2 to 3 days out of every cycle because of heavy periods. There are women who require blood transfusions because of menorrhagia. So this gets treated. There are some contraceptives that actually cause menorrhagia. So if menorrhagia begins after the use of a new contraceptive, that needs to be considered as a possible reason. Another common cause is fibroids. Treatments, they want to find out what the cause is and treat it. GnRH antagonists may be used to shrink the fibroids. Fibroids can be removed surgically. A myomectomy to remove those fibroid tumors may leave the uterus weakened in that place. So if someone has had that done, they may not be a candidate for vaginal birth if they should become pregnant afterward. There can be a risk of uterine rupture. When childbearing is complete, a lot of women with very heavy bleeding just go have a hysterectomy. Then they don't have to deal with it anymore. A less invasive or less total approach to that would be to embolize the uterine artery. So the uterus is left in place, but the uterine artery is damaged so that it so that blood flows drastically decrease, and that decreases bleeding. That also has to be done after childbearing is complete. because if the uterus is not getting enough blood flow, it cannot support a pregnancy. Any patient with menorrhagia should be monitored for anemia. Metrorrhagia is mid-cycle. This is mid-cycle bleeding. Metrorrhagia may be caused by some contraceptives. It's called breakthrough bleeding. Some women also may have spotting at ovulation or implantation. Abnormal uterine bleeding is bleeding that is irregular or not related to regular menstrual bleeding. It can be caused by hormone alterations, or it can be caused by diseases. A lot of times it's related to not ovulating that cycle, but it can be caused by some cancers. So it needs to be evaluated every time. Okay, so anytime someone has abnormal uterine bleeding, they're bleeding when it's not time for their period, it needs to be evaluated because there are some cancers that can cause that. An acute bleeding episode, at times that abnormal uterine bleeding will start and they can't get it to stop. Estrogen may be used to stop that bleeding. A D&C, dilation and curettage, where the cervix is dilated and suction is just used to remove the uterine lining. A combined estrogen progestin oral contraceptive may be taken for 3 months after that to try as a kind of reset. If it's recurrent and severe, that patient may get a uterine ablation. They go in and ablate. They damage the endometrial lining so that it will not proliferate. That decreases bleeding. After ablation, the uterus can no longer support a pregnancy. So when we're looking at these menstrual complications, the thing to remember is what is the cause? Why is the person having this abnormal bleeding? And does that cause have risks that we need to address? And then does that symptom affect that patient's life? How does that symptom impact the patient's life? Okay, so the next section is going to be about infections.